All right, can you hear me?
Yes.
Yes.
Okay. So I'm showing you the NCLEX test plan again, and you'll see how many times blood transfusion is mentioned on this document. Search. All right, here we go. So here's one. All they're saying is this one: administer blood products and evaluate client response. Administer blood products, evaluate client response. Same thing, identify, these are the steps for, well, a summary of the steps for giving a blood transfusion. So here's 3 bullets, but again, they mention administering the blood and evaluating the client response. So that means we're covering indication, meaning who gets what type of blood product. That way you know how to administer it. This describes the procedure. It mentions the procedure, meaning you verify the order, the correct blood type. That means you're checking it with a second practitioner or second professional. You identify the patient, correct cost matching, and make sure there's consent. And you have the appropriate venous access device, correct size of the IV catheter, and correct blood, meaning correct blood for the correct indication, and that the access site works. Then documenting, and again, administer the blood product and evaluating the client response. Okay, so it's repeatedly mentioned, so we know it's on the NCLEX. All right, so that's done. We established that. Okay, let's go to the procedure. We'll skip the blood donation process. We'll just look at your role. A few things here to be aware of. When transfusion blood products and the patient is immunocompromised, meaning it's important to understand that what is blood? Is that considered cells or tissues?
Yes. It'll be tissue, right?
Okay. And it comes from a different person, correct?
Yes.
Okay, so is this a form of transplantation?
No.
Yes.
No.
The most, it is.
Yes.
It is the most
Yes.
common transplant being done every single day. So we're getting tissue and cells from one person, giving it to another person. So it is the most common type of transplant. So therefore, is it subject to antigen-antibody reactions?
Yes.
Yes. Okay. Now, since this is a foreign body, is there a chance of a reaction, chance of a rejection?
Yes.
Yes.
Okay, let me describe rejection. So we will cover transplant rejection, solid organ transplant rejection next semester. However, since we're on this topic, it's important to know that let's describe what is rejection. When in rejection, it is the host or the recipient that will reject the graft. So in this particular instance, if I'm the donor and then you give me someone else's blood, although the same type, you cross-matched it, I will have the risk of rejecting that cell or tissue. So I'm going to, my immune cells.
Plan if you have extra area. Because
Well,
are we gonna do this? You are trying to have
Beijinho,
You are doing
your,
this
your, your mic is on.
can I continue?
Yeah, Professor, sorry.
Okay. All right, so what was I talking about? All right, so if I'm the host, I'm receiving someone else's blood. So there's a risk that I will reject that blood. Okay, so in the concept of rejection, it's the host attacking the graft, okay, the cell or the organ or the tissue that is being given to me. So my immune system cells recognizing that it is a foreign object, doesn't look like my own, I will reject it, I will destroy it, okay? But that's rejection. Now, in the case if it's reversed, if let's say the host this time is immunocompromised, like in this particular paragraph is talking about here, that means that the host, which is me, have a depressed or suppressed immune system, meaning my immune system cells, let's say I have HIV, AIDS, maybe, or maybe I'm taking steroids, or I have cancer, or I'm receiving chemo, radiation, because chemo and radiation will destroy both cancerous and normal cells, especially rapidly dividing cells, which comprises my entire immune system. So am I able to protect myself from viruses, bacteria, etc.?
No.
No. Okay. So in that particular instance, if you give me a foreign cell or tissue, or in this particular example, blood components, which contain viable white blood cells, who will attack who? Since my immune system is suppressed, can I attack the graft, or is the
No.
graft going to attack me?
It'll attack you.
Okay, all right. So this paragraph is talking about that particular scenario. So if the recipient of the blood transfusion has immunosuppression or is immunocompromised for the various reasons I mentioned, chemotherapy, radiation, or long-term steroid therapy, or have HIV, AIDS, or any other immunocompromising condition, they are unable to protect themselves. So therefore, in that case, the blood component given to them must be free of any viable lymphocytes or white blood cells. We call that a leukopoor blood product, meaning this one right here, leukocyte poor, or simply called leukopoor. This is important to note before you administer the blood. Make sure it is leukopoor, because you might kill your patient by giving that blood, because the white blood cells present in the blood that is not leukocyte poor can literally attack the host, the recipient of the blood, killing that patient. Any question about this concept?
No.
Okay, so how do they do that? Well, they irradiate it. So this is the process by which they destroy white blood cells in a given bag of blood. So that this is the process of eliminating the white blood cells in there. I mean, it's not 100% free of WBCs, but pretty much it's about 99% free. Okay, there's probably a few cells there still remaining, a few white blood cells, but not enough to kill the host, okay, or the recipient. So this is the process, as mentioned here, to prevent graft versus host disease. All right, so very, very important. All right, let's go now to the blood components first, the indication. So let's find out what each blood product is given for. So on a test question, I'll give you the patient's condition, what is their problem, and you pick the appropriate blood product. Or let's say I'll simply ask, this blood product can be given to which type of person, okay, which type of patient. Sorry, wrong page. So this is on page 897, table 28-4. These are the commonly used or transfused blood and blood components. Now we will only cover the first three, namely, we'll skip whole blood because whole blood is not frequently administered. Particularly, we give this whole blood means this is the entire bag of blood donated by a common donor. So chances are when you donate blood, we get whole blood. Okay, so that's pure blood. Now, when the blood bank or the blood center, whoever took the donation, gets it, they divide it into other products. So they process the whole blood and they can break it into, they can sell it 3 different ways. They can either separate the red blood cells from it, then we call it packed red blood cells now, or they can also get platelets. Okay, they'll separate the platelets, but in that case, these are only the platelets that are in the whole blood. So that means it's not much. It'll probably be, if the platelets are obtained from a bag of whole blood, they need like 10 of those bags of whole blood in order to get 1 bag of platelets. Does that make sense?
Yes.
Okay, so that means it's not much. It's mostly red blood cells in whole blood. There are platelets in there, but if they take it out, that means they'll need about 10 donors of whole blood to get 1 entire blood of platelets. Okay, if that's the case, if that's the source of the platelets, we call that pool like a swimming pool, meaning they pooled it from a bunch of up to 10 whole blood donors, right? So meaning that bag of blood came from up to 10 different people. The reason why they can do that is because platelets don't have a blood type, meaning they don't have a blood type antigen on them. So regardless of blood type of these whole blood, meaning let's say we have 10 donors that have type B, type A, B, or O, it doesn't matter. If you pull them together, put them in the same bag, it's okay, all right? Because again, platelets do not carry a blood type antigen on them. So it doesn't matter where it came from. Now, for some patients, though, that have cancer or are immunocompromised with histories of blood transfusion reactions, those patients are special. So they need a single donor platelet. Okay, so this is here's the indication. So used for repeated treatment of alloimmunization risk. Again, these patients that receive single donor platelets are usually cancer patients. Okay, doesn't matter if they're adults or children, so they require single donor. The benefit of a single donor platelet is we know who it is, and we can there's only 1 person who we cross match to. The problem with the pooled platelet is you can't, if there's a reaction, you can't trace the reaction because you already put those up to 10 donor platelets into 1 bag, so it's hard to tell from which donor did the patient react to. Does that make sense?
Yes.
Okay, so
Yes.
so therefore, if it's a regular patient, let's say trauma patient or a patient who came in with DIC, remember DIC patients are given plasma, correct? So we can give them random or pooled platelets. However, for special patients who are immunocompromised, cancer patients, we give them only single donor platelets. Single donor platelets are very rare donors, meaning there's a limited number of people there who are single donors, because it again takes a long time, about 2 hours or up to 3 hours to donate a single bag of platelets. All right. And then the third one we'll discuss and test is plasma. Okay, so we only test packed red blood cells, platelets, both random and single donor, and then finally plasma. Okay, so how do you answer the question? So here are the indications. The key to remembering the indication is quite simple. So if you know what's in that bag of blood, then you know who gets it. So let's start with packed red blood cells. So what's in it? What's in that pack of red blood cells?
Plasma.
Packed red blood cells. What's in there?
It says it's red blood cells with plasma, some platelets, and white
It's
blood
not
cells.
much plasma. Well, plasma, of course, can we put just cells in there with no water? Is it possible? You just put solid cells of blood with no liquid?
No.
No. Okay, so of course there's some plasma there. Okay, it has to be in some liquid form, correct? So that's what it is. Basically, we can disregard the plasma. I mean, this is not enough plasma to benefit the recipient. Okay, it's very little, it's negligible. So mostly what's in there, majority, 99% is red blood.
Red blood cells.
Okay, that's about it. Of course, there's some platelets also in there. Again, negligible. Okay, the plasma and the platelets that are in there, they're uh, just part of the process. Okay, some of them got left behind, but it's really a bag of red blood cells. So who would get or benefit from this blood product? Who would you give red blood cells to?
Someone who has who's losing red blood cells.
Okay,
Like
Hypovolemia.
someone with anemia.
all right. So here's the indication. So whatever type of anemia they have, acute blood loss, or if they have a nutritional deficiency anemia, or if they have a absorption or malnutrition type of anemia, does not matter. Or trauma victim, does not matter. The patient needs red blood cells. They're low, they're anemia. No matter the cause of that anemia, they get red blood cells. Any question?
No.
All right, let's go to platelets. Again, I already mentioned who gets pooled or random platelets. Anybody, okay? Single donor platelets, who gets this special bag?
People that's
Immune compromised such as cancer
Okay,
patients.
so thank you, and Miss Morris. So this is for special patients who are immunocompromised. Again, mostly cancer patients and other immunocompromised patients. So we prefer giving them single donor platelets because they're very likely to have a reaction, and it's very easy for us to identify the donor. All right. So indication, okay, third column, indication. So when do we give red blood cells? I mean, platelets, sorry. Well, if the patient is actively bleeding, regardless
When
of
you
the
have low
number.
platelets.
Yeah, so the platelet here, the threshold again is 5 to 10,000. Some facilities transfuse below 20,000. Some transfuse below 30,000. But most facilities I've worked for, at least, transfuse under 20,000. We rarely see platelet transfusion ordered above 30,000. So it must be considerably low. The reason for that is because of the lifespan of the platelets. Platelet cells do not last more than 10 days. So their lives are pretty short. They only live 7 to 10 days. So in our body, they're normally replaced every 7 to 10 days. So you have new platelets every week, literally. So therefore, if they only live that long, can we store platelets for a long time on the shelf or in a
No.
refrigerator? No. So we need a fresh supply of platelets every time. So every day we need platelet donors. There's not enough platelets to go around from whole blood, even if we harvest from every single whole blood donor. There's just simply never enough platelets. So if you have time, you may want to consider being a platelet donor. We have several patients who need these, and that's also the reason why we do not indiscriminately transfuse it, because if you transfuse it too early, let's say the patient's platelet count is still above 30,000, above 20,000, it's pretty useless because really by the time the patient actually needs it, the platelets are already gone, correct? I mean, they've already passed their lives. Do you agree?
Yes.
Okay, so we only
Yeah.
use them, we only give them, and when the patient actually needs it, when it's actually useful. All right.
So question, Professor, you can't
Yeah.
freeze it?
I'm sorry.
You can't like freeze it, like super freeze or whatever? Like
Well, the problem with, let's say you do that, it's not really going to stop the aging. Does that make sense? They
yes.
continue to age. So yeah, you can freeze it, but it doesn't stop the aging process. They still, it's not like, let's say I was born today, right? I'm
Mhm.
not going to be 1 day old forever.
Okay, yeah, I got it.
Yes. Yeah, they continue to
Mhm.
age, so it doesn't really make sense. I mean, you can
Just at a
keep
very slow
alive,
rate.
but yeah, but then they'll still die when
Right.
the time passes. Okay. Last one is plasma. So red blood cells, we know the packed red blood cells, there's red blood cells in there, platelets, there's only platelets in there. Plasma contains three things. So there's water in there, coagulation factors are in there, antibodies are in there. All right. So oh no, I forgot. There's also protein in there. Okay, so four things in plasma: water mostly, and then protein in the form of albumin, and then we have coagulation factors. So all the clotting factors you mentioned last week in your presentation are in plasma. And a complement is part of the coagulation cascade, and then the antibodies are in there. Okay, so who will benefit from plasma? Who will need plasma? If they contain antibodies, they contain clotting factors, and they contain albumin.
Patients who have like septic shock are very like low in proteins
Okay,
and
so
plasma protein.
you mentioned DIC last week, correct? So here's the
Correct.
indication: bleeding in patients, coagulation factor deficiency. So that could be your DIC patients, although this is not specific. For hemophilia patients, they have to be given only the specific clotting factors, namely 8 and 9, if it's A and B. But pretty much DIC or bleeding patients can benefit from plasma. Another would be, let's say you have a patient who overdosed on warfarin. Do you know what is warfarin?
Anticoagulant for daily therapy.
All right, so warfarin or Coumadin, the brand name, is a common anticoagulant, and that anticoagulant is a vitamin K antagonist. So therefore, how it works is since we need vitamin K in order to make clotting factors, so how warfarin works is it antagonizes or inhibits the formation of vitamin K. So therefore, if you don't have vitamin K, can you make clotting factors?
No.
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 So that's how warfarin works. That's how it prevents clotting. Okay, that's how that anticoagulant works. So therefore, if you're taking warfarin and you took too much of it, what do you not have anymore?
Clotting factor.
Clotting factor. So would it make sense that if you overdose on warfarin, I'll give you plasma?
Yes.
Yes, because what does plasma contain again?
Clotting factors such as
Okay.
vitamin K.
Very good. We discussed plasmapheresis, right? During myasthenia gravis. Yeah.
No.
Yes.
No?
No.
Yes.
Yes, we did. Anyway, refresh your memory. Plasmapheresis has the same concept as dialysis, hemodialysis. So in hemodialysis, we took the patient's blood out of his body, right? And then put it into a dialyzer, a machine, a dialyzing machine. And what did the machine remove?
Plasma.
No.
It-
Hemodialysis.
It basically it cleans out. I mean, I thought it removed the plasma and then it put it back and it cleans it out and then put it back in.
We didn't talk about plasma and
Clean
hemodialysis.
No,
out
no,
the
not
blood.
no,
The
the
waste
blood.
products from the blood.
Yeah, so
The
what was removed by the dialyzer?
The blood.
Waste
Remove-
products such as
it
protein.
removes-
Blood?
It removes the antibodies from the plasma.
Waste
Wait a minute.
products.
Are we talking about plasmapheresis or talking about hemodialysis? I was talking
Hemodialysis.
about
Hemodialysis.
Hemodialysis.
Plasma. Okay.
Okay, are you okay? Are we on hemodialysis first?
Yes.
All right, so in hemodialysis, I was asking, so what did the machine remove?
Waste products.
What else? Very good.
Excess fluid.
Very good.
Protein.
It removed excess fluid, excess electrolytes, excess waste products. Okay, so it acts like a kidney. So it did the job of the kidney. Now, in plasmapheresis, the process is similar. So we still take the patient's blood out of the body and then return it. During the period that it's out of the body though, in plasmapheresis, what was the machine removing?
The antibodies.
Plasma, you know?
It was removing plasma. Now,
Yeah, that's what I said.
what is in the plasma? Since this procedure is done for patients with autoimmune diseases, so what do you think is the purpose of doing plasmapheresis in patients with autoimmune disorders?
Sorry, what was
Professor-
the question?
Repeat
I
the
thought-
question, Professor.
I thought it's to remove the antibodies that are attacking the immune system.
Correct. So the concept is the same. This procedure involves removing the patient's blood momentarily out of the patient's body into a machine, just like the dialyzer, and then returning it to the patient. During the time that it was outside the body and inside the machine, what was the machine doing or removing from the patient's blood in plasmapheresis?
It was removing the plasma.
The procedure is called what?
Plasmapheresis.
So what is it removing?
Plasma.
Plasma.
Plasma. Why? What is in plasma? Why is it removed in autoimmune disorders?
The antibodies.
It contains antibodies. However, can the machine distinguish between autoantibodies and good antibodies?
No.
No.
No, it just removes the plasma. That's all we can do. So plasmapheresis is also called plasma exchange. So while the patient is having the procedure, the machine removes the patient's plasma and then replaces it. At the same time, we will exchange it. So that's why it's called a plasma exchange. So we'll remove your plasma first, and then we'll give you somebody else's plasma. Does that make sense?
Yes.
All right. So those are the indications. I can discuss the others too, but they're not really commonly given. So what are the three commonly transfused blood products?
Packed red blood cells, platelets, and
Platelets.
what is it called? Single donor.
Doesn't matter. Platelets are platelets. So plaque red blood cells.
Platelets and whole blood.
I never talked about whole blood.
So I don't know.
Plasma.
No, it's
Ah.
plasma.
Okay.
Plasma,
So
platelets, and
plaque red
RBC.
blood cells. Yeah. For the exam, what are you studying?
Plasma, platelets, and RBC.
Okay. Alrighty. Let's go to the procedure now.
Professor Milagros said she got kicked out.
Well, I don't see her in the. Oh, okay. I see. Okay. Before we go.
Professor.
Yes.
Sorry, the three red blood, the three plasma plate and the RBC. You said that's gonna be an exam too for next week.
Yeah.
Okay, thank
And the
you.
final too. And next
The
semester.
final. Okay.
All right, so here's the procedure. There are two charts here, chart 28-3, chart 28-4. Start with 28-3. This chart is for packed red blood cells, and these are the literal steps for giving the transfusion. So check the order. Check that there was a type and cross done. Check for consent. Consent must be on file, and the consent must be recent. For most facilities, they'll take a consent obtained within the last month, or at least during this present admission, meaning we don't need different consent every single time we do a procedure. I mean, a blood transfusion. Okay, and it's also specific, meaning a surgical consent does not replace a blood consent. Okay, so this is a specific document giving consent specifically for blood transfusion. All right, so make sure it's on file. And then once you have that, you explain the procedure to the patient. What we really want to tell the patient about are two things. So we want them to cooperate with us because we need their help in order for us to identify any reactions, because we can see signs, but can you see symptoms?
No.
No. Patient must
the
report
transfusion.
symptoms. Right. You know the difference
Wait.
between a sign and a symptom, right? What is a sign?
Yeah, but I was saying,
What you see?
We
yeah,
can
signs
see
are what you
signs.
see.
Can you see symptoms?
No, they have to
No,
say it.
only
It's
can you
what the
see
patient
nausea?
said.
Can you
Yes, I
see
got it.
nausea? Can you see itching?
No,
No, you can
No.
feel scratching, but you cannot see itching, right?
See, itching. Okay, yeah.
So meaning you need the patient's cooperation. You need the patient to be able to help you identify any reaction. So you educate them. Which reaction? Well, I showed you the test plan. Did the NCLEX test plan specify the type of reaction that they'll be testing you on?
No, I don't think I catch that part.
No, nothing. It just said administer blood products and evaluate client response. Now we don't know what type of response that patient will have because there are a multitude of blood transfusion reactions. So for the exam, this semester and next semester, and on the NCLEX, you will be tested on any of the possible reactions. Okay, so we'll discuss all of them. So after explaining the procedure, then you're ready. Take the baseline vital signs. We need a set of vital signs so we can compare any changes when the patient receives the blood transfusion. We will note because what type of solution do you think a blood product will be? Let's say packed red blood cells. What type of solution is that? Is that isotonic, hypertonic, or hypotonic?
The isotonic, right?
What is an isotonic solution?
Lactate Wenger.
What else?
Normal saline.
Normal saline 0.9.
What makes that isotonic?
Because it
It-
has the same solute
Same
concentration and water
concentration.
concentration.
Correct.
Because it has, okay.
Right. So a bag of red blood cells, is that the same concentration as plasma?
No,
Technically, no, because it has more red blood cells in it. Because meaning, can you compare a bag of blood with saline and lactated ringers?
no,
No, that's night and day, right? So it's a hypertonic solution. So can it cause fluid overload?
yes,
Yes, because it contains a lot of molecules. It contains albumin molecules. It contains red blood cells. It contains some platelets, some white blood cells. Okay, so it's a very hypertonic solution. So therefore, if the patient has any problems like heart failure, kidney disease, what is your concern?
Fluid overload.
Fluid
Fluid
overload.
overload. Okay. So if that's your patient's history, meaning you know that a patient has heart failure, has kidney injury, acute or chronic, what is your responsibility?
Check the fluid status.
check the patient, the fluid.
INOs?
Now, what does this statement say here? Number 6. What does number 6 say?
No, if signs of increased fluids overload present, contact primary provider to discuss potential need for a prescription for a diuretic as warranted.
All right, there's your answer. All right. Hand hygiene, wear gloves. This is standard precautions. However, we need to wear gloves because this is something wet and it's not ours. Okay, this is somebody else's body fluids. Before, these are all done before these are all assessments, right? So we need to prepare before we go get the blood from the blood bank. You can also send someone to go get it for you. That's no problem. You just you give them a patient's label. That way the person or the staff member is aware of who the patient is that will receive blood. Okay. In the meantime, make sure your patient has the appropriate size IV cannula. By appropriate, meaning we mean number 20 gauge or bigger. So besides 20, what other size IV catheters is appropriate? 20 or bigger. So what other number sizes are appropriate?
18.
What else?
16.
Okay, all right, just making sure. I don't want someone saying 22, 24. Okay, so it's 20 is the minimum, 18, 16 will do. Okay, 20 is enough. We also need to set up the saline and the in blood tubing. I mean, we did this in class, correct? In lab a few weeks ago.
Blood tubing.
I mean, we practiced blood transfusion in the lab, right?
No,
What do you
We
mean?
only did piggyback.
Not
We
yet.
did regular.
Not
Yeah.
yet. Not yet.
Do this in this semester?
No, probably last semester.
We just did
Not
piggyback
yet.
with the fluids and the medication.
Okay, so you haven't seen a blood tubing yet?
No.
No.
All right, so when we get back in school, we'll do this. Okay, so you remember priming a primary bag, correct?
Yes.
All right, and I showed you how to prime a secondary bag.
Yes, you did.
Okay, it's pretty much the same. Okay, so it's just a different tubing. This tubing has two piercing pins. Okay, so one for blood, one for saline. But the process of priming the line with the IV solution because you need to prime it with saline first before you prime blood. All right, so you're basically priming a bag of saline, as simple as that. All right, the blood tubing will have a filter, so it will filter if there are any clots in there, so at least that won't go into the patient or any other particulate matter. So, but we're basically filtering out clots that are in that bag. All right. Okay, so once you're ready, then you can, so it's already set up, the patient, you got consent, you got vital signs, you check the labs, okay, we have typed and crossed, we know the blood count is low, so it's appropriate, okay, we have an IV access, and you finally prime the tubing, so everything's ready. All we're missing now is just the bag of blood. So everything's set up, you can go send someone now, or you can go get it yourself, doesn't matter. So go get the blood. They will only release 1 unit at a time. They will not give you multiple bags. They'll only release 1 bag. So let's say there's an order for 2, 3, 4 units of blood to be transfused. The blood bank will give you 1 at a time. Unless it's in the ER, the blood bank can release an unlimited amounts of blood in the ER because sometimes we transfuse multiple bags at once, okay, in the ER, but all other units, no. So you need to double check it with another nurse or physician. Now, I know this says another nurse or physician. Did it mention it has to be a registered nurse? Did it say
No.
registered nurse? No.
No, it just says nurse.
Right. So therefore, can an LPN check it with you?
Yes.
Absolutely. Other books will say with another professional, with another health professional is a licensed professional. That's the term. So with another licensed professional, so who are licensed professionals?
Physicians,
Well,
nurses.
Licensed professionals
okay, any licensed
or L?
professional. So can we have an RT respiratory therapist
No.
with us?
Yes.
No.
Licensed.
Wait.
Yeah.
No, I thought you had to have like another nurse.
Sorry. A physical therapist. Do they have a license?
No,
Yes.
They have
Yeah.
certificate.
they have a
They have-
certificate.
Physical therapists have a certificate? There's a doctor of physical therapy. You think they have certificates?
No,
they have a
No.
They take the board exam
They have
just
a
like you do.
license.
Okay, they are all licensed professionals. Okay, so a doctor, whether it's medical doctor or a doctor of osteopathy, they are all licensed. So all of those can check blood with you. Only an RN actually administers the blood, but the second person checking it with you, because it's a simple procedure. I mean, all they're reading are numbers and names. Okay? Can a LPN do that?
Absolutely.
Yeah. If an LPN is giving medications and they're checking names and labels every single day, of course, this is just another label. Are we clear? Yes or no?
Yes, we're clear.
Okay,
Yes,
so an
yes, we're clear.
LPN can check it with you, okay? Can the LPN hang and administer the blood?
No.
Only an RN, okay? But the second person checking it with you, can it be anybody?
No, just someone that's a licensed.
Any licensed
Anyone
professional.
licensed?
All right. Okay. So after we check that, so you scan the blood bag, there will be about maybe 4 things you scan. So you scan the blood product, you scan the expiration date, you scan the donor number. I know there's 4 barcodes on it. So you'll scan 4 and then you're good to go. Check the blood for anything that could be in there. Gas bubbles usually is not a good sign. Okay, there shouldn't be any gas bubbles there. A few bubbles, yeah, of course, that's normal when the bag is shook, right? But if you have, see, like foamy bubbles, okay, that's too many bubbles. Okay, so that means that indicates bacterial growth in the bag. So that means there was some contamination in the process of blood donation, and then the bacteria multiplied during storage. All right. Now, the bag of blood the transfusion must be started within 30 minutes from when it was removed from the blood bank. So the person, whether that's you or another person who took the blood from the blood bank, the first thing the blood bank personnel will do after they take the bag of blood out of the refrigerator is there's a piece of paper, which is the transfusion slip, tied with a rubber band around it. They'll take that out and then look at the clock and then put the time, okay, before they even start checking the name. Okay, that's the first thing they'll do because the clock starts running the moment the bag of blood left the refrigerator. So when you receive it, you have 30 minutes from that time to begin the transfusion. What if the time is way past 30 minutes by the time you received it? Because let's say the person you sent took a detour. Let's say they went to visit their girlfriend or went outside to go get a smoke. And it was a whole pack of cigarettes. So it took a while. All right. So what is your responsibility? If the bag of blood got to you close to or beyond 30 minutes, meaning there's absolutely no way you can start the transfusion within 30 minutes from that time. What is your
Return it back
responsibility?
to blood bank.
Sorry?
You would return it back to the blood bank,
Very good. That's
not
the answer.
administer it.
Right. You put it back in the refrigerator, not in the staff refrigerator. Take it back to the blood bank. They can still use it for someone else, but not for your patient. Okay, you won't have enough time to finish. So our maximum, so we're still on the packed red blood cells, so you have 4 hours to finish it. So it started from the 4 hours started from the time the bag of blood was taken out of the refrigerator. So that's why if you weren't able to start it within 30 minutes from removal, it's best that you return it, okay? Because there's just no way you will finish in 4 hours. Okay. So let's say it arrived within 30 minutes. Let's say maybe just 10. Okay, plenty of time. So now you spike the bag of blood just like you spike a IV bag. Okay, so you already set the saline already. It's primed. You prime the blood tubing with the saline, and now you just spike the blood. All right, so should be slow. 5 mLs per minute is equal to how many mLs per hour? How many minutes?
300.
How many minutes
300.
an hour? Okay, so but is that slow or fast? That's pretty
That's
fast,
fast.
right? Yeah.
Fast.
So I would go maybe uh anywhere between 50 or 100 ml per hour, or you can go as high as 120. But let me let you know that the reaction is dose related for anything, whether it's a drug, a blood product, or whatever, food. Okay. So if someone's allergic to it, or a patient has a reaction to a drug, food, or blood, it is dose related. So what would you prefer? The patient receives a lot of it or just a little?
A little.
A little. Again, the reaction is dose related. So the meaning the more they receive of the substance that they're allergic to, then the worse the reaction will be. So I prefer running it slow. So I can choose 50 or 100 up to 120. I know this says up to 300 mLs per hour, but I would never do that. All right. So you run it, let's say maximum 120 ml per hour. So observe the patient for the 15 minutes. You do not leave the patient's bedside. You stay there. So if I were you, I would just have my WOW, my computer on wheels, inside the room with the patient, and you're charting. Okay, so you do whatever you need to do. You cannot leave the patient. So you just within arm's reach with the patient. That way you can stop the blood transfusion anytime the patient has a reaction. So you already talked to the patient over here, okay, before you went and got the blood. So you educated them on the possible reactions and then report them to you, okay? So you stay with the patient for the first 15 minutes. Reason is most transfusion reactions occur during this time. So if nothing happens within 15 minutes, then you can increase the transfusion rate. So you don't have to stay at 120. You can increase it to 130, whatever you need. Now, any typical bag of blood, cracked red blood cells, contains about 300 ml, more or less. Some 330, 308, doesn't matter. It's about 300 ml. So if you have 4 hours to finish it, what would be your rate? What would be a safe rate? Now consider things can go wrong. The IV access could infiltrate. Patient may have diarrhea and may have to run to the bathroom. A multitude of things could go wrong, okay, and will interrupt the blood transfusion procedure. So what would be a reasonable rate for you to finish in 4 hours? From the time it left the refrigerator.
15.
15 what?
ml per hour.
You do 15 mLs per hour and you have 4 hours. So if you give only 15 every hour, that's 60.
So 75 or
There's
like
300 mLs in that bag.
125?
All right. So you already started at 120. So why would we said increase it, not decrease the rate, right? So you can go 125, even 130, but 125 is good. So that should give you about 3 hours, right? That's guaranteeing you that it will finish in 3 hours, okay? Other factors to consider, of course, are the patient's age, okay? Can the patient handle the volume that you're giving every hour? Remember, this is a hypertonic solution. Consider a patient's heart function, kidney functions, pulmonary function. Okay, so this is all nurse's judgment. The doctor will not specify the rate. This is all the nurse's responsibility. You're the boss, okay, with the blood transfusion. So you use your own judgment. Can this patient handle the rate that you're administering the blood product at? Does that make sense?
Yes.
Yes.
Okay, so you're the boss. The patient is trusting you, depending on you to make the right decision. So, all right. We'll get to the types of reactions and what the signs and symptoms are next. So if nothing happens throughout the transfusion, now it will vary, follow agency policy about how often you take the vital signs. Okay, so after the first 15 minutes here, because you took vital signs here, right? You took a baseline vital signs, and then 15 minutes after you started the transfusion, you took another set of vital signs and observed the patient for any of the reactions you educated them on, and then nothing happens, you continue. Now, each hospital will have a different policy on the frequency of your vital signs measurement. So just follow the NCLEX, or your textbook doesn't specify because of that reason. So some hospitals will have every 30 minutes, some every hour, some just 3 times. The baseline, the 15 minutes after, and then at the end. Okay, I've had hospitals that do that only 3 times. But if you were the nurse, would you be confident? Would you be comfortable with just taking it at the beginning, 15 minutes later, and at the end? Is that enough for you? Okay, so again,
No, you have to
use
keep
your
checking.
okay, so just use your judgment, okay? Or anytime the patient says something, the action is the same anyway. We stop. So we'll look at that, your actions for each transfusion reaction after we finish this. Post procedure, so watch the patient. Vital signs, again, it's a hypertonic solution. Check if for signs of fluid overload. The neck veins, shortness of breath, lung sounds, okay? And if it is, then call the doctor, ask for a diuretic. Dispose of the materials. Where do the blood bag, the empty blood bag, and the blood tubing, which still contains blood, where do we throw them away? Where do we put them?
The biohazard bags.
Very good. Go look for a red biohazard bin, throw it there. Then document the procedure. How did the patient handle it? All right. There are possibilities of a delayed reaction, so continue to monitor the patient hours after the transfusion ended, okay? And here are a few other things. Hopefully you already know them, that we don't have to read this, okay? But I'll say it anyway, so don't add anything else. The only solution compatible with blood is saline. We use that to prime the line and also to flush the line. Don't add it with any medications. If you have to, let's say the patient has no other IV site, that's it, just one number 20 on the left arm. Okay, you don't have anything else. You tried to start a new IV access, can't do it. Okay, patient's a hard stick. So all you do is pause the blood transfusion, flush the line with saline, and then administer whatever you have to push. Okay. But if it's a long transfusion, a long infusion of another drug, you just make the right judgment. Okay, so if it's gonna be too long, that will make you go over the 4 hours for the packed red blood cells, then better just notify the physician that you can't do it. Okay, that the blood has to finish, and then they'll have to find a different way to administer whatever medications they need, okay? Any question about packed red blood cells? This is just the packed red blood cells. Any questions? Very good. Let's go to platelets and plasma now. Chart 28-4. The first part is really the same, okay? I know this says 22 gauge. I would never give any blood product with a 22. I would still stick with a 20. So you still do consent, blah, blah, blah. Okay. Yes, there was a comment, question?
No, I just said okay. I'm writing it in my notes. 20.
Alrighty, okay. So here, so you did the same, got consent, and then prepared the blood tubing. Okay, you primed the line with saline. Okay, so now you got consent, you got the order. Now go send someone, or you go yourself, get the blood product. So for platelets or plasma, it's the same. Except for this part, the blood type is not really necessary for platelets. It is right here, not necessary for platelets, but it is necessary for plasma. Okay, so plasma must be the same blood type as the patient. Donor and patient must have the same blood type for packed red blood cells and plasma. Platelets, though, not necessary. I mentioned that earlier. Proof is the pooled platelets. Okay, we have up to 10 different donors, not even the same blood type. Okay, so it doesn't matter for platelets. Okay, so check the blood product again. Make sure there's no contaminants in there. Okay, so nothing solid. All right. This one is transfused much faster. So how many hours did we have for packed red blood cells?
4.
4 hours maximum. This one, you only have 30 to 60 minutes from the time they left the refrigerator. Again, for plasma and platelets, you only have 30 to 60 minutes. So how fast is this given? So let's say there's
Really fast.
100 ml on there. So how many mLs per hour will you run it?
$30 to 60 minutes.
No, how many mLs per hour?
Oh, ml.
So you only have an
It
hour.
said,
And you said how much is it?
yeah, didn't it say 5 ml per minute?
No, that's for blood.
Yeah. I mean, you still do the same, 15 minutes, but I'm saying if you only have 30 to 60 minutes to finish, how many mLs per
Yeah.
hour will you run it? Say it's a 300 ml bag. So what will be your rate?
Same 125 ml.
300.
You only have 30 to 60 minutes to finish. The time
300.
began
Maximum is
from the
300.
time the platelet or the plasma bag was taken out of the refrigerator. Let's say the bag contains 300 ml of platelets or plasma. How many mLs per hour will you run it?
175.
300.
You only have 30
least
to 60 minutes to finish 300 ml. So how
At
many
least
mLs per hour?
300.
At least 300. Okay, 300 or more. You can go 350, you can go 600. But just the same, the first 15 minutes, you still run it slow, say 120, but only those 15 minutes. After that, no reaction, speed it up. Okay, speed it up to 300 or more. Usually we go 400, 350, 400. Okay, that should give you enough time to finish in less than an hour. Because remember, this time began, this 60-minute maximum here began when it started ticking when you took
the
it
bag got out the
from the
fridge.
blood bank, correct? So you have to give it really fast, okay?
But if we give it too fast, right? Doesn't that cause like a reaction or something?
It's
Or
not,
no, that's safe?
well, you checked it within the first 15 minutes, correct? You started slow
Yes.
during the first 15 minutes. You started at 120.
Yes.
Okay, so
Okay.
15 minutes later, nothing happened. So can we speed it up?
Yeah.
Yes, so you can go 400. Okay, so that should let you finish way before the 60-minute time frame, right? But throughout, do the same, check for signs and symptoms of reaction, and then after that, document and then flush the line. All right. So the main difference really here is in the checking and also in the time of transfusion. I'm sorry, the rate of transfusion. All right, for the reactions, I'm not discussing all of them. That's your job two things I'm testing you on are signs and symptoms. How do you know the signs and symptoms of each reaction? Because you need to identify. The action part is the easy part, what to do, because here are the signs and symptoms. Let's say with acute hemolytic reaction, which is one of the most, it's rare, especially in this age, because the most common cause of this is ABO incompatibility here, meaning the patient received blood, which is the wrong blood type. That's the most common cause of acute hemolytic reaction. I mean, does this happen often? I mean, how many people check the blood type?
No.
Yeah, it's very rare, but believe me, it still happens. And when it does, I mean, it's a really serious occurrence, right? I mean,
Lawsuit.
event. Yeah, it should not have happened, but it does happen. Although very rare again. You just do your job checking with another nurse, with another licensed professional, you should be fine. The intervention is really the same. You're told to stop stop the transfusion and then call the doctor. Same thing here, allergic reaction. Okay, so these are your signs and symptoms. Okay. So some of them will say prevention. So let's say this patient has a history of a blood transfusion reaction. Some doctors will tell you to pre-medicate the patient with, let's say, Benadryl, which is an antihistamine, diphenhydramine, before the transfusion. Or let's say the patient has a febrile reaction here, which is
Wait,
the most
I'm
type.
sorry, Professor.
Yeah,
Question. You could administer Benadryl before a blood transfusion,
absolutely.
but don't Benadryl knock you out?
Well, if you give like 100 or high dose, yeah, but 25, 50, it's fine. Or 12.5.
Okay.
Right. Febrile non-hemolytic reaction. This is the most common type right here. It's the most common type of transfusion reaction. What your action is going to depend on the patient's other symptoms. If it's a low-grade fever, let's say 100.4, not like 101, the doctor usually will just tell you, after you stop the transfusion, you call, correct? So when you call, they'll say, okay, what's the temperature, and how are the other vital signs? What are the patient's other symptoms? The most common order is to continue the transfusion and then just give the patient Tylenol. All right, meaning if it's just fever, and it's not a really high fever and there are no other symptoms, usually the doctor will just tell you, okay, give Tylenol and then continue, and then observe, and then let me know if anything else happens. But the first action, what is your first action?
You check the blood type.
No.
To stop the
No,
transfusion.
wait, what?
You saw a reaction.
To stop
Oh, when we said
transfusion.
you stop the transfusion.
Stop and then call the doctor. It's the same for each of these. Stop, call the doctor. Then depending on the transfusion reaction, they'll give you orders, okay? So allergic reaction, fluid overload, or TACO. There's also lung injury. This is pretty serious. Bacterial contamination is the only type of reaction that you can get from an autologous blood donation or blood transfusion. What is an autologous blood transfusion? Autologous, auto, like auto, automatic, auto. Okay, an auto.
Isn't that when you have like two people and their blood was taken from the same individual?
Okay, So you're kind of right, but it's one person. So let's say I
Oh, so,
donated
yeah,
my
one
own
person.
blood, right? So I have an elective procedure. So let's say I'm having a knee replacement in January. So today is October. Doctor recommended, okay, why don't you bank blood? So we'll deposit it, put it in blood bank. We'll give it back to you because you're gonna need a transfusion. I say, okay, fine. So I donated my own blood, put it in the fridge, and then after my or during my procedure, I'll withdraw it and then I'll get a transfusion. Okay, will I have a reaction? I mean, it's my own blood.
No, because it's your
No.
own blood, which
However,
is safer.
if it got contaminated during storage or during my donation, it may contain bacteria. So this is the only, again, this is the only type of reaction possible from an autologous blood transfusion. Any question?
No.
We'll discuss acute lung injury because it doesn't matter what the cause of the acute lung injury is. Acute lung injury can kill. All right. Again, the discussion is quite long. We'll do this in the 5th semester. There's also a acute hemolytic reaction. There's also a delayed hemolytic reaction. This is quite rare. They still put it in the book, but this is almost unheard of. I mean, we have good screening and cross-matching. I mean, we screen the donors for most common blood-borne diseases like hepatitis, AIDS, CMV. Okay, so these are unheard of. I mean, I don't remember the last time we had these cases because again, we do a good job with screening, okay, typing, screening, and cross-matching. All right, any questions on the procedure? Blood products. So our goal today was
Blood transfusions.
yeah, indications. We did that. Who gets what type of blood? We discussed the all three most commonly transfused blood products, and then we discussed in detail the procedure, pre-procedure, pre-transfusion, and then what to do during the transfusion. We discussed the duration and the rate for each of the three blood products and each possible patient response, which can include a possible reaction, and we know what to do. Any questions about blood products?